Uh, Hello, sir.
Yeah, tell me.
So, sir, 3, 2,
Yeah.
1. Sir, you are live. You can start the session. Over.
Thank you, Pooja. Thank you, Lupin, team of Lupin, especially Mr. Lokande, who has organized this webinar on beta blockers. Let me introduce myself. I am Dr. Satish Roplekar, Senior Interventional Cardiologist from Aurangabad. I am sharing my cell number as well as email ID on the first slide. If you want to interact with me, even after the presentation, you are most welcome. So, I am going to discuss the role of beta blockers in the management of heart failure. And I'm going to emphasize on heart failure with preserved ejection fraction as well as heart failure with reduced ejection fraction. Now, dear friends, as you know, the beta blockers have been classified as selective and non-selective beta blockers. And the newer beta blockers, that is the third generation beta blockers, are non-selective beta blockers with alpha blocking activity. Selective beta blockers, they will act only on beta 1 receptors and they will decrease the heart rate, contractility of the myocardium, and the conduction from the conduction system. At the juxtaglomeralar apparatus, they will decrease the renin release, thereby decrease the RAS activity. As I mentioned, the third generation beta blockers, for example, carvedilol, which has got, in addition, the alpha blocking activity, they will have a vasodilatory effect on the vessels by blocking the alpha 1 adrenergic receptor and thereby increase the nitric oxide production, which is a endothelial friendly molecule. So in nutshell, what we get, the beneficial effects, cardiovascular beneficial effects, are decreased blood pressure, myocardial oxygen demand, water and salt retention, and decreased oxidative and inflammatory stress, and the attenuated cardiovascular remodeling. So this is how the beta blockers, they will act. In the continuum, or in the at many points in the cardiovascular continuum, the beta blockers exert their beneficial effects. For example, let us begin with risk factors. So right at the risk factor level, the beta blockers will help to control hypertension. Some of the beta blockers like carvedilol, they have metabolic effects. Through their metabolic effects, they will have positive effect on the diabetes and hyperlipidemia, thereby help to control the diabetes and glucose levels. Supposing if the patient develops atherosclerosis and left ventricular hypertrophy because of uncontrolled hypertension, some of the beta blockers like nebivolol, they regress the LV hypertrophy and help to control the atherosclerosis or retard the progress of atherosclerosis. Supposing if the patient develops coronary heart disease and myocardial ischemia, then beta blockers, they have anti-ischemic effect, thereby control the myocardial ischemia and relief of angina. Now, because of coronary thrombosis, if the patient develops myocardial infarction, through the neurohormonal activation, the beta blockers will block the epinephrine and norepinephrine actions, thereby prevent the arrhythmias which are associated with acute myocardial infarction, like dangerous ventricular tachycardias and ventricular fibrillation, thereby help to prevent the sudden cardiac death. As you know, after myocardial infarction, the patient tends to develop, or the ventricle tends to develop remodeling. So there is a direct action. Through their direct action on the ventricles, the beta blockers will prevent or minimize the remodeling, and the ventricular enlargement is also minimized. Thereby, preventing the congestive heart failure and controlling the congestive heart failure and ultimately the death. So thus beta blockers are useful at many points in the cardiovascular continuum. But somehow, though it has so much of beneficial effects at every level, uh, there's still a reservation among the physicians to use beta blockers. And this apprehension is because of the negative inotropic effects. And that's why, beta blockers were contraindicated till late 90s. So till then, many trials with AC inhibitors like consensus trial, VF trial, SOLVE trial, TRACE trial, IR trial, all these trials proved beyond doubt the beneficial effects of AC inhibitors. And that's why, beta blockers lagged behind actually, because by then, AC inhibitors, they created a listening amongst the medical fraternity about their usefulness. But in late 90s, various beta blocker trials like MDC trial, CBIS-1, CBIS-2, Merit HF, Comet, Seniors trial, and US carvedilol study. All these trials showed beyond doubt the mortality benefit, survival benefit of beta blockers on the patients of myocardial infarction and coronary heart disease. So beta blockers came to stay in the management of heart failure. Now, once you know that beta blockers are useful in the management of heart failure and cardiovascular continuum, the question is which beta blockers? Not all beta blockers are recommended in the guidelines by European Society and American Heart Association. Only carvedilol, metoprolol, bisoprolol, and nebivolol have been shown to improve overall and event-free survival in NYHA class 2 to 3 heart failure patients. The non-selective beta blocker like propranolol or even a beta-selective beta blocker like atenolol are really contraindicated for their use in heart failure. So, dear viewers, to treat congestive heart failure and to reduce the cardiovascular mortality, 5 pharmacological agents have been shown to, they have proven to be effective in reducing the all-cause mortality. Which are these 5 pillars? First is beta blocker. They have shown to reduce the mortality by 34%. AC inhibitors have shown to reduce the mortality by 16%, ARBs by 17%. MRA like spironolactone and eplerenone have shown to reduce the mortality by 30%. Of late, ERNI has shown to reduce the mortality by 20%. Hydralazine has been shown to reduce the mortality by 43%. And of course, the device therapy like CRT and ICD, they are also useful in the management of congestive heart failure if this pharmacological therapy is inadequate. Now, coming to the recommendations of use of beta blockers by the guidelines, European Society of Cardiology and American College of Cardiology, they recommend beta blocker use in patients whose ejection fraction is less than 40% with or without heart failure, in both the situations, that is STEMI as well as NSTEMI. However, patients of STEMI whose ejection fraction is more than 40% with or without heart failure, the European Society recommend use of beta blockers, and their recommendation and guideline shows it is 2AB recommendation, whereas the American College, it's 1B. For NSTEMI with ejection fraction of less than more than 40%, the recommendation is 2AC. So, dear friends, the Beta blockers have shown tremendous robust data. There is a robust data on the mortality benefit as well as survival benefit in many trials. For example, US carvedilol program and Copernicus trial where carvedilol was studied. In US carvedilol program, the risk reduction was 65% with improved survival, and in Copernicus trial, the risk reduction was 35% with improved survival. In CBIS-2 trial, where bisoprolol was studied, the risk reduction was 34% with improved survival. And in MERIT-HF, where metoprolol was studied, the risk reduction was 34% and the mortality was reduced significantly with metoprolol compared to placebo. So all these studies have shown undisputable beneficial effects of beta blockers in these patients. It's the robust data. Now, treatment of 15 to 43 patients with heart failure will prevent one death, and thus beta blockers are very effective in patients with heart failure. The only precaution that one has to follow while using beta blockers in clinical practice, the dictum is start low and go slow. So the evidence-based doses of beta blockers in heart failure with reduced ejection fraction are bisoprolol, you start with 1.25 milligram once a day, carvedilol 3.125 milligram twice a day, metoprolol succinate, not tartarate, in the dose of 12.5 milligram once a day, and nebivolol 1.25 to 2.5 milligram once a day. Once you ensure that beta blockers are well tolerated, these doses are well tolerated by the patient, then you double the dose every 2 weeks. Don't be in a hurry to push up the doses of beta blockers because the patients are likely to develop side effects of beta blockers. So, you have to individualize patient-wise. There is no fixed rule or dictum. So start low and go slow to win the race. Now, interestingly, I want to mention one important point, that is dose-response relationship. Patients of congestive heart failure are more sensitive to beta blockers. So, for example, the dose at which you will get therapeutic response in patients who don't have heart failure, and the dose at which you will get the adverse events, in those patients who don't have heart failure, the margin is wide. However, in patients with congestive heart failure, the dose at which you will get therapeutic response and the dose at which you will start developing the adverse events because of beta blockers, the margin is very narrow. That's why you have to give the maximum tolerable dose to the patient. At times, the patient may not achieve the recommended target dose, but the maximum tolerable dose is also okay for that patient. Now, this has been already covered. The reduction of mortality by ACE inhibitors is 16%, which has been proven in SOLVE trial. Beta blockers have shown to reduce the mortality by 34% in CBIS trial. And in RALS trial, MRAs have shown to reduce the mortality by 30%. And ARBs, where candesartan was used, 17% reduction in the mortality was shown. Now, this is the very important slide. Let us spend some time understanding this slide. Those patients who have heart failure with reduced ejection fraction, the effects of beta blockers, which are based on the randomized control trials, it has shown to reduce the mortality significantly, and it has shown to reduce the number of hospitalizations. So the recommendations are you must use beta blockers very widely in this particular clinical scenario and situation of heart failure with reduced ejection fraction. Now, what about patients of heart failure with preserved ejection fraction, what we call as HFPEF? Now here, the effects of beta blockers there is as such very insufficient data on major adverse cardiac outcomes. So, the recommendation is there is no robust data to support the use of beta blockers in patients of HFpEF. However, if these patients of HFpEF, they have associated systemic hypertension or they have chronic atrial fibrillation, then yes, you are justified in using beta blockers. And as such, large randomized controlled trials are needed to prove its beneficial effects. What about post-ACS clinical scenario? The immediate effects of beta blockers have been shown to reduce the mortality as well as reinfarction. However, they have shown to increase the risk of heart failure and incidence of cardiogenic shock. If you use beta blockers unscrupulously in a scenario of acute myocardial infarction on presentation when the blood pressure is less than 100 millimeters systolic. So, you have to use beta blockers only if the systolic blood pressure is more than 100 millimeters systolic. And start with the low dose again and titrate gradually to avoid the adverse effects. And maximally, you can continue the treatment for 3 years or permanently if the patient develops overt heart failure. And large contemporary randomized controlled trials are in progress to study long-term effects in patients without left ventricular dysfunction. What about stable patients of coronary artery disease like stable angina without recent ACS and with normal left ventricular function? There is insufficient data on major adverse cardiac outcomes. However, one can use beta blockers for relief of angina to increase the effort tolerance of patients of angina, and large, again, randomized controlled trials are needed to show the mortality benefit. Now, dear friends, if you come across a patient with heart failure with reduced ejection fraction less than 40%, then you ask the question to yourself, does the patient has contraindication to use beta blockers? And what are the contraindications? Cardiogenic shock, symptomatic bradycardia, or AV blocks like second degree or third degree AV block. These are the contraindications to use beta blockers. And if there are no contraindications to use beta blockers, then you initiate and up titrate the beta blockers, which have been recommended by European Society and American College of Cardiology, that is metoprolol, carvedilol, and bisoprolol in the recommended doses, which we have already discussed earlier. At regular intervals, maybe 10 days or 2 weeks, you reassess the patient and see whether the patient is intolerant to the use of beta blockers and whether there is any scope to increase the dose. If the patient is tolerant and there are no side effects, then you can step up the doses and achieve the maximally tolerated doses. And dear friends, dear viewers, even after achieving the target doses of beta blockers, if the heart rate is more than 70 beats per minute, then here is the indication to use ivabradine. The recommendations for ivabradine are very low in this particular flow diagram. And if the patient is having some side effects and is intolerant to the initial doses of beta blockers, then you assess why the patient is intolerant, whether the patient is volume depleted. So you decrease the dose of diuretic and you decrease the dose of diuretics, and you can switch the beta blocker from say, for example, bisoprolol or metoprolol to carvedilol, and you minimize the other AVN blockers like calcium channel blockers. And at the outset, if the patient is really having contraindication, then of course beta blockers are inappropriate and they should not be used. Now, coming to HFPEF, which is a very important entity nowadays. heart failure with preserved ejection fraction. Here, the pathophysiology is there are changes in LV relaxation and filling. The left ventricle is stiff, so there occurs a problem in filling of left ventricle. And the LV and LA remodeling occurs, the geometry alters, and that's why the filling is affected. As I mentioned, LV is stiff, and that's why there is reduced LV compliance, and there occurs changes in systemic and pulmonary vascular compliance. There occurs changes in skeletal muscle and endothelial function, and through visceral metabolism, which occurs in metabolic syndrome of centrally obese patients who have hypertension, diabetes, hyperlipidemia, and other things. They have the pro-inflammatory and pro-fibrotic signaling and cytokines which are released, and because of that, the patient develops the LV hypertrophy and reduced compliance, and with preserved ejection fraction, there is a filling defect. Now, in every patient of heart failure with preserved ejection fraction, you should always measure and assess the patient by doing 2D echocardiogram for looking at the LV wall thickness. This can also be measured by cardiac MRI, and you should measure the LA volume, and you should assess the systolic function. Normally, the ejection fraction is preserved in HFPEF, but you should assess the global longitudinal strain, and the diastolic dysfunction is a main problem in HFPEF, which can be done by mitral velocities. Normally in diastolic dysfunction, the A wave is greater than E wave. Similarly, mitral annular velocities by tissue Doppler and TR velocities also can assess the diastolic function of the heart. Now, interestingly, it has been observed that advancing age, systemic hypertension, atrial fibrillation, COPD, and even anemia are known to be more associated with HFpEF compared to HFpEF. So, all these comorbid conditions can produce heart failure with preserved ejection fraction. So you start wondering why the patient is breathless in such patients. So, you should find out the comorbid conditions in patients who have preserved ejection fraction and having the features of heart failure. Now, what are the mechanisms underlying atrial fibrillation, which is very common in HFpEF? As I mentioned, the features of metabolic syndrome like diabetes, obesity, hypertension, or obstructive sleep apnea, they are known to exert conduction abnormalities in the conduction system. They have abbreviated refractoriness and some structural abnormalities through pro-inflammatory and cytokines. So there occurs a problem with re-entry, and on top of that, the remodeling of the ventricle will have abnormal atomicity, delayed after depolarization or early after depolarization. All these, factors, they contribute to a focus which will induce atrial arrhythmias, leading to atrial fibrillation, which may last long and become a chronic atrial fibrillation. Now, dear viewers, heart rate is an important parameter to assess the all-cause mortality. And heart rate is determined by the epinephrine and norepinephrine levels, that is sympathetic activity. This is a wonderful slide. I love to show it in most of my presentations. Plasma norepinephrine is a strong predictor of death. In the early phase of myocardial infarction, 3 neurohormonal factors are released, that is ANF, that is atrial natriuretic factor, catecholamines, and third one is renin-angiotensin system is activated. But in the late phase of myocardial infarction, there is a steady increase in the atrial natriuretic factor and catecholamines. However, the renin-angiotensin system is known to remain dormant. And the renin-angiotensin-aldosterone system is again activated only at a time when the ventricular dysfunction sets in and the patient develops overt heart failure, where you have to make use of diuretics to control the symptoms. So in the early and late phase of myocardial infarction, as there is a steady rise of ANF and catecholamines, there is definitely a role of beta blockers which will counteract the actions of catecholamines. Hon et al. Have studied 106 patients of moderate to severe heart failure, and they have followed up them for almost 5 years. And what they have shown, the probability of survival was maximum in those patients who were maintaining the plasma norepinephrine level of 200 picograms per ml compared to steadily increasing norepinephrine levels, and the probability of survival was least in those patients whose norepinephrine levels were more than 1200 picograms per ml. So there is definitely a role of beta blockers to play in the management of heart failure. Now, dear friends, whether it is 2012 guidelines or 2016 European Society guidelines, no treatment has yet been shown convincingly to reduce morbidity and mortality in patients with HFPEF. Remember, heart failure with preserved ejection fraction. Now, when you come across a patient of HFPEF, your aim of the therapy should be to reduce the symptoms and to prevent acute decompensation by correcting anemia, correcting COPD status, and other things. And you should make an aim to improve the exercise capacity by recommending regular isotonic exercises by the patient. Now, here there are some clinical trials in heart failure with preserved ejection fraction. You know, many trials, for example, DITCH study where digoxin was used, CHARM-P, candesartan was used, SWEDIC trial, carvedilol was used, PEP, CHF, perindopril was used, CNES trial, nebivolol was used, I-Preserve, irbesartan, RAM-PEF, eplerenone, ELAND, nebivolol, TOPCAT, spironolactone, and RELAX, sildenafil. You know, all these trials with various different molecules. And in all these trials, the ejection fraction, if you see the fourth column, it was definitely more than 40-45%. And what the results show, there was no reduction in composite of death or heart failure, no mortality benefit, no significant change in composite diastolic filling, and you know, there was no convincing evidence that beta blockers really favored using in HFpEF. Now, the treatment success, you know, this is a very interesting comparison between treatment patients of HFrEF and HFpEF. So, you know, most of the molecules, whether it is beta blockers, ACE inhibitors, digitalis, MRA, you know, sacubitril, valsartan, CRTD, exercise, etc., they have all shown to increase or have positive effects in patients with HFrEF. But if you see the HFpEF patients with preserved ejection fraction, you know, only to some extent MRAs and exercise, they have shown to be successful in patients with heart failure with preserved ejection fraction. And there are certain implant devices which will measure the end diastolic pressure and alter the hemodynamics of the patient and give some improvement in patients with HFpEF. Similarity and differences in HFpEF versus HFrEF. You know, the heart failure with preserved ejection fraction is more common in women, Hypertension and atrial fibrillation and diabetes was more common in HFPEF compared to HFrEF. Previous myocardial infarction and coronary disease was more common in patients with reduced ejection fraction, and the renal failure, obesity, and atrial fibrillation and chronic lung disease was more common in patients with heart failure with preserved ejection fraction. The systolic dysfunction, of course, was obviously more pronounced in heart failure with reduced ejection fraction compared to preserved ejection fraction, and the diastolic dysfunction was present in both the situations. So what is the therapy of patients of heart failure with preserved ejection fraction? Sodium and fluid restriction. So make use of diuretics, give nitrates to reduce the preload so that the ventricular filling becomes proper. And you can achieve neurohormonal modulation. You have to treat the antecedent and comorbid conditions like controlling hypertension, adequately controlling the diabetes, prevention of ischemia or treating ischemia, weight loss, improvement in the renal functions, OSA treatment by CPAP or maybe BPAP, and correction of BiPAP or correction of anemia, and the optimization of cardiac functional status can be achieved by controlling the heart rate rhythm by regular exercises. And if the patient has got atrial fibrillation, in addition to patients who have preserved ejection fraction, of course, maintaining the sinus rhythm is more proper and right thing to do. But if you are not able to achieve normal sinus rhythm, then at least you should control the ventricular rate in patients with atrial fibrillation. Now, interestingly, it has been observed that prevalence of atrial fibrillation in patients of heart failure goes on increasing. The prevalence goes on increasing as the NYHA class worsens. So if you see this particular diagram, there was 50% presence of atrial fibrillation in those patients who were in NYHA class 4 compared to NYHA 1 or 2, where the incidence was 5 to 10%. And if you treat heart failure in sinus rhythm, you can definitely prevent or delay at least the onset of atrial fibrillation. This has been shown by various trials. So you should treat heart failure adequately, vigorously, energetically in those patients who are having normal sinus rhythm to prevent atrial fibrillation. Now, coming to the all-cause mortality in heart failure with reduced ejection fraction, depending upon the heart rate, sinus rhythm. Beta blockers in heart failure collaborative group meta-analysis have shown but if you use beta blockers, then you get the maximum mortality benefit, or all-cause mortality has been shown to be significantly reduced in those patients who have less than 70 beats per minute heart rate compared to more than 70 beats per minute. So the maximum mortality was seen in those patients who were having a heart rate of more than 90 beats per minute. But that doesn't hold true, if the patient has got atrial fibrillation in patients with heart failure with reduced ejection fraction. So the beta blockers have not shown to give the mortality benefit by controlling the ventricular rate. So the mortality was more or less same whether you maintain the heart rate of less than 70 or more than 90. So this was one particular study by Kotecha published in Journal of American College of Cardiology in 2017. However, dear friends, the latest study, which has been published in Cardiology Research and Practice in 2020, here the beta blockers have shown to decrease the mortality in HFPEF in patients associated with atrial fibrillation. So there is definitely a role of beta blockers even in patients of heart failure with preserved ejection fraction, especially who are having atrial fibrillation. Now, there is again apprehension amongst the clinicians to use beta blockers in elderly patients. And, we are carried away whether the older generation people will tolerate beta blockers or not. But it has been shown that elderly also, they benefit equally from beta blockers. This has been studied in the meta-analysis of more than 12,000 patients. And if you see, these are the trials like Copernicus, sub-analysis of Copernicus, Carvedilol, US, CBS2, Merit HF. All these trials have shown the mortality benefit even in elderly patients with systolic heart failure. Now, the effects of beta blockers on morbidity and mortality in a population, again, more than 12,000 patients, elderly patients with heart failure, and the survival benefit has been shown. The higher doses of beta blockers, there was cumulative survival was more compared to the lower doses of beta blockers or no beta blockers. So even in elderly patients, if the patient is able to tolerate, you can still step up the doses to the extent possible till the maximal tolerable dose by the patient. So, what happens after myocardial infarction? You should make judicious use of beta blockers. Why I'm saying judicious? If the patient's blood pressure, systolic blood pressure is less than 100, then intravenous beta blockers or beta blockers for the fear of pushing them into cardiogenic shock, or patient's blood pressure is more than 100, then judicious use of beta blockers with oral beta blockers can be done. And if there is no contraindication, then you can give beta blockers. And if the patient develops systolic dysfunction after myocardial infarction, then beta blockers should be given on a long-term basis, more than 3 years or 3 years or so. But if there is no LV systolic dysfunction, by prompt and proper thrombolysis, you recanalize and give a salvaged myocardium to the patient, and at the end of the day, if the ejection fraction is preserved, then there is a questionable role of beta blockers on the long-term basis. So the consensus recommendation on beta blocker in heart failure, all patients with a stable class 2 or 3 heart failure due to LV systolic dysfunction should receive beta blockers. There is no question on that, no controversy on that. Of course, ACE inhibitors are usually given in such patients earlier. So on top of ACE inhibitors, you can give beta blockers unless they have some contraindication to use, like, symptomatic bradycardia. And treatment with beta blockers should not be delayed until the patient is found to be resistant to treatment with other drugs. Because there is a withdrawal effect, and now, if you have some questions, I'll be happy to answer them.
Sir, I have put some questions in the chat box.
Okay. Yeah, good. Yeah. Now here, Ganesh Gupta has asked one question. which beta blocker you prefer in young hypertensive patients? Here, you should make use of selective beta blockers, either bisoprolol or metoprolol. But if the patient is having some side effects like impotence and all, you can try giving, carvedilol, which has got less prevalence of impotence. So either of these three you can give to treat hypertension in younger generation. The second question by Mr. Ravindra is 100 milligrams of metoprolol can be given in CHF for long term? If yes, then how many months? That is very interesting and very important question that he has put forth. In everybody's clinical practice, I don't think many physicians would achieve this dose of 100 milligrams of metoprolol in patients of heart failure with reduced ejection fraction. But for example, if some patients is able to tolerate without any side effects or adverse events or adverse side effects, then yes, you should give metoprolol. And it has been recommended to use for 3 years after myocardial infarction. But if the patient continues to have signs and symptoms of heart failure, then still you can continue to use metoprolol. Now, Dr. Deepak has asked one question. Which beta blocker is safe in heart failure management? Dr. Deepak, the ESC and that is European Society of Cardiology and American College of Cardiology have recommended only 3 beta blockers to be used or 4 beta blockers to be used in patients of heart failure. That is carvedilol, bisoprolol, metoprolol, and nebivolol. So atenolol and propranolol or sotalol should not be used, or rather they are contraindicated to be used. I hope I am satisfying their questions. Which one is best beta blocker, metoprolol or bisoprolol? And what is the reason for choosing the same drug? This is by again Ravindra. Actually, there is no comparative trial between metoprolol and bisoprolol. Both are equally good. Both are beta-1 selective beta blockers, and both have shown the beneficial effects, not only in controlling hypertension, but even in patients of heart failure with reduced ejection fraction. Both have shown mortality benefit. Yeah.
Hello, sir.
Yeah, go ahead.
So, sir, now there is no question. So, sir, can we wait for a few minutes if another question comes?
Yeah, we'll wait.
Okay, sir. Thank you.
I just want to ask a feedback about the presentation where there was any interruption in between because of the internet support, or whether it was proper.
No, sir, it was proper, sir. Proper.
Sorry?
Sir, it was proper. There was interruption, but it was for few seconds, like 5 to 2 seconds, not more than that.
Okay.
So, sir, now there is no question. So, sir, can we end or can we wait for another questions?
I have no issues because the attendance appears to be very meager. So I don't expect any more questions. because the list of participants, I don't know. I'm not able to see here.
So, sir, can we conclude? Hello, sir.
Yeah,
So, sir, shall we wait or shall we conclude?
I think we should conclude now.
Okay, sir. So, sir, now I'm ending the session. So, sir, on behalf of organizer, I thank you for your insightful and educative talk. Thank you, sir.
Thank you. Thank you and good night.
Good night, sir. Good night.
So I'll leave the meeting now.
Yes, sir. Yes, sir.